Good morning, everybody. I'm really excited to be here to kick off the session this morning. The Focal Therapy Society is really excited to bring this collaborative meeting together with SIRS, and it's a really nice opportunity to rub elbows with our colleagues that still do robotic surgery and still like to cut the prostate out. I know you still do surgery, but we'll let it go right now. So I'd like to introduce, we have Dr. Phillips from Northwell Health and Dr. Solomon, the Martini Clinic. I didn't want to misspeak. And we'd like to welcome Dr. Befar Ehdaie to speak on the quantification of pattern 4 candidacy for active surveillance and focal therapy. Unfortunately, he is not here and he's providing a video presentation.
Good morning, my name is Befar Ehdaie. It is an honor to present this morning at the Focal Therapy Society meeting. The title of my talk is Quantification of Gleason Pattern 4 and Prostate Cancer Outcomes. We were interested to understand whether the heterogeneous outcomes of men who had Gleason 7 prostate cancer are associated with the volume of pattern 4. And we see this in taking care of patients every day. We also observe differences in outcomes when we evaluate our own clinical trials. The table on the right comes from our multi-center clinical trial evaluating high-intensity frequency ultrasound focal therapy for men with baseline grade group 2 and grade 3 prostate cancer. It is notable that men who had grade group 3 prostate cancer at baseline were at increased risk of multifocal higher grade prostate cancer as compared to men with grade group 2 prostate cancer. We hypothesized that the differences in outcomes in these men are more associated with the total volume of pattern 4 as opposed to differences in proportions of pattern 3 and pattern 4 prostate cancer. I have no relevant disclosures in regards to our talk this morning. We all agree that grade group 1 prostate cancer patients should be managed with active surveillance. Importantly, increasing volume of grade group 1 prostate cancer on biopsy is not associated with worse outcomes. In this study from Memorial Sloan Kettering, we evaluated patients who underwent radical prostatectomy in our historic cohort with Gleason 3+3 prostate cancer. When evaluating biopsy volume of Gleason 3+3, we note that patients who underwent surgery were not at worse outcomes with higher volume disease. However, when evaluating grade group 2 prostate cancers for active surveillance, despite universal guideline endorsement, specific language is utilized to emphasize patient selection and volume of pattern 4. However, we do not have methods to quantify pattern 4, and there is a paucity of data whether truly increasing length of pattern 4 is associated with worse prostate cancer outcomes. We know from the historic and landmark PROTECT trial that patients with Gleason 7 prostate cancer had very good outcomes despite being treated with surgery, radiation, or active surveillance. However, in men with Gleason 7 prostate cancer, we again note heterogeneous outcomes. Specifically, amongst the men who died from prostate cancer with Gleason 7 disease, we note that these men were high volume on systematic biopsy. Upwards of 7 cores were positive in 5 of 8 men who died with Gleason 7 prostate cancer in the active surveillance cohort. Therefore, volume matters. This study from the University of Michigan evaluated increasing percentage of Gleason pattern 4 at biopsy and surgical outcomes. They observed that as the percentage of pattern 4 increased on biopsy, these men were at increased risk of biochemical recurrence and adverse pathology after surgery. We were interested to evaluate different quantification methods of pattern 4, specifically percentage of pattern 4 compared to total length of pattern 4 across all biopsy cores. Since 2017 at Memorial Sloan Kettering, we have prospectively labeled the total volume of prostate cancer and specifically Gleason Pattern 4 on all biopsy cores. Therefore, we retrospectively reviewed patients who underwent radical prostatectomy since 2017 with Gleason 7 or higher prostate cancer. We note that as the volume of pattern 4 increases on biopsy, the risk of adverse pathology defined as extracapsular extension, seminal vesicle involvement, or systemic disease also increases. And when we compare different prediction models incorporating percentage of pattern 4 or millimeters of pattern 4 across all biopsy cores, we note that patients who are selected for treatment with millimeters of prostate cancer are better risk stratified and cancer outcomes determined. Of note, when we subsequently evaluated biochemical recurrence in our patient population, we again noted that with increasing volume of total pattern 4 across all biopsy cores, there is an increased risk of biochemical recurrence. As you look at the horizontal line in the figure on the left, we see that at 2 millimeters of total length pattern 4 across all biopsy cores, these patients have similar risk as having grade group 1 prostate cancer in regards to prostate cancer outcomes after surgery. Of note, we evaluate MRI targeted cores by looking at the average length across all cores in the same region. Next, we wanted to evaluate this quantification method of pattern 4 in patients with grade group 2 prostate cancer managed with active surveillance at Memorial Sloan Kettering. We evaluated 61 patients in 2017 who had the length of pattern 4 measured at the time of biopsy. It is important to note that the features of Gleason Pattern 4, whether it's total length of pattern 4 compared to proportions of pattern 4, can tell us a different story. Looking at our progression criteria in these patients, including grade group progression or increases in length of Gleason Pattern 4, there is a varied outcome measure. For example, if you look at a patient, the second patient who had grade group 3 prostate cancer and labeled disease reclassification, the total length of pattern 4 on diagnostic biopsy was 0.81 millimeters. This increased very small amounts to 2.2 millimeters on subsequent surveillance biopsy, an increase of only 1.4 millimeters. However, when looking at the percentage of grade group Gleason Pattern 4, this patient went from 25% Gleason Pattern 4, designating them a Gleason 3+4, to 55% Gleason Pattern 4, defining disease reclassification based on grade group. So therefore, we see that despite grade group reclassification, the total length of pattern 4 may not change. This is also in reverse, in which patients who had no grade group reassignment had a significant increase in the total length of Gleason Pattern 4. For example, the fourth patient went from a total length of Gleason Pattern 4 of 0.44 millimeters to almost 10 millimeters of pattern 4, an almost tenfold increase in the length of pattern 4. But this patient remained Gleason 3+4 because the overall percentage of Gleason Pattern 4 only went from almost 10% to less than 37%. Therefore, we can better risk stratify our patients if we quantify the total length of pattern 4 compared to proportions of pattern 3 and pattern 4. How does MRI targeted cores affect our prostate risk stratification? Well, we understand that systematic biopsy cores can represent a discordant results compared to our MR targeted cores. Currently, if a patient underwent a systematic biopsy and an MR targeted biopsy, we assign their Gleason grade based on the highest of these two assessments. However, we note in our study that when we compare risk of biochemical recurrence and adverse pathology, that patients who have discordant MR targeted and systematic biopsy cores, their risk is intermediate between the two risk scores. Therefore, if a patient has a systematic biopsy of only grade group 1 prostate cancer and the MR targeted core demonstrates Gleason grade group 2, their risk does not equal patients with Gleason grade group 2 and instead in between the risk of grade group 2 and grade group 1. This is important as we risk assign these patients and select patients for focal therapy and active surveillance. In conclusion, quantification of Gleason pattern 4 improves risk stratifications for patients with intermediate risk prostate cancer. High volume Gleason pattern 4 is associated with worse oncologic outcomes in multifocal higher grade prostate cancer. Selection criteria for active surveillance and focal therapy should incorporate volume pattern 4. Specifically, low volume Gleason pattern 4 can be defined as less than 2 millimeters total length across all biopsy cores. Be cautious reassigning disease risk based on a higher grade disease detected only on MR targeted cores. Thank you for your attention.
Thank you for staying on time, Befar. We really appreciate that.